These are chapters 5 through 9. It's all about the delivery systems that we have with anesthesia. So I'm not going to go over every single slide. I'm going to kind of hit and miss, but that doesn't mean that what's on there is not important. It's just in an effort to allow you to read through the slides or read the text. And I will be highlighting some slides. But the other slides are important and you may have test questions over them, so don't skip. So let's get started. We're going to start with chapter 5, which is all about the syringe. There's 3 essential components to a syringe. You have this actual syringe, the needle, and the cartridge. So if you're going to be, if your dentist says, why don't we need some new syringes, and would you look through the ordering catalog and see which ones that you would like. These are the things that you need to look for. You need to look for a syringe that's durable. It needs to be able to accept a wide variety of needles. Some of them only accept certain ones, and cartridges from different manufacturers. So it needs to be inexpensive, lightweight, and really simple to use. It needs to provide for effective aspiration so that blood can be easily seen. So let's go over what aspiration is. An aspiration is when you have a syringe in your hand and it has the needle and the cartridge and a full cartridge. And you will press the thumb ring with your thumb, and that is going to expel the local anesthetic. So if you lightly tap up on the top of, with your thumb so that you reach the top of the inside of the ring, the thumb ring, then it makes the needle go up just a little bit. And I'm talking like maybe a millimeter. So it's just, you raise your thumb up and just a little teeny bit. And what that's doing is that it's drawing whatever that it's in. If it's in tissue, or if like we're going to do oranges, if it's inside the orange, it's going to draw the orange, the juice of the orange back into the syringe, because you're reversing the order. So that's called an aspiration. And when we are injecting, we inject to where we know we need to go because we've memorized that, and maybe we go in 5 millimeters on a particular injection. We'll go in 5 millimeters and then we pull up just ever so slight on that thumb ring and we look at the cartridge. And what we should be seeing are just little tiny, teeny tiny little bubbles coming back up. If, however, we get red in there, then we know that we are inside of a blood vessel. So that's the only way that we can tell if we're inside of a blood vessel or not. So at that point, you would remove the syringe from the orange or from the person's mouth and remove it slowly, and you change your cartridge and you change your needle, and to where you have a clean needle and a clean brand new cartridge, and then you go in, you penetrate the tissue again. You never penetrate in the same hole that you went in before, but you can be right next to it because that's probably the right area that you've already looked at. That's an aspiration, and whatever syringe that you get needs to be an aspirating syringe. Some of the syringes that they have are not aspirating syringes. They just go in, there's no way to kind of pull it, give it a little tug the opposite way and see if you're in a blood vessel or not, because you never ever want to inject the anesthetic into a blood vessel. So it's the only way that we can tell is by using an aspirating syringe. So our clinic, we use non-disposable because we autoclave them and reuse the syringe. We use a breech loading, which means it's loaded from the side of the syringe. It's metallic. It's a cartridge type that you can use a cartridge with, and it needs to be able to be aspirating. So all of those things, I'm going to let you go ahead and read through the different parts, the barrel, and all of that. They also have a computer-controlled local anesthetic delivery system. It's called a C-CLAD for computer controlled local anesthetic delivery. Okay, it's also known as the wand. This is what I know it for. We have these in each one of our operatories as far as the dental hygienist to be able to use the wand in. That's really nice. It's a mechanical device, and it self-aspirates and releases a really steady flow of local anesthetic, and it slowly. You hold it like a needle, like in a pin grasp, since there's no thumb ring. It's just a very long case, and you'll see a picture of it in a minute. But they have different types, aspirating, self-aspirating, plastic, metal, disposable, a pressure syringe, safety syringes, and these computer controlled. And you'll see pictures of it. So here's the advantages and disadvantages. I would heavily look over these. We don't want anything that weighs really heavy or too big or too complicated to use. We want it to be rust resistant, and we want to be able to see the cartridge and for it to last a long time. Disadvantages of a plastic reusable aspirating. They have plastic. And you can reuse them. So the reason that they did this is because it wasn't quite so scary. It eliminated that clinical, scary metal look, and it was lightweight. The cartridge was visible. You can aspirate it. You need to be able to aspirate it with one hand. The hand that you're giving the injection with, you need to be able just to pull up on that same thumb. And so there were a lot of good things about that. The disadvantages is that there weren't a lot of different sizes, so it could be too big for really small handed operators. There was a possibility of infection if you didn't properly care for those plastic aspirating syringes, and there was you could autoclave them, but there was a deterioration of plastic after you repeatedly autoclaved it, so they weren't long lasting at all. Here's the different parts of taken apart of a metal syringe. This is this circle here, A, is the thumb ring. This is what you press down on to release the anesthetic out of this side. And your thumb would be right here, and then when you aspirate, you just lift your thumb up a little bit to right here on the top of the inside, and you just pull up about 1 millimeter, just ever so slight, and that's how you aspirate it. But these are all the different types of the barrel and the harpoon. This harpoon goes into the actual anesthetic. It goes in up here, and then your needle screws on to the back. But I'd look through all of those. These are just a portion of the different kinds of needles that they have. They have this right here. This blue one is Orchix, and that doesn't go into the skin. That is 2.5% lidocaine and 2.5% provocaine, and it numbs the gum tissue. And you put it down into the sulcus, and it numbs down there, but it does not numb the tooth. So it's like a topical. You have different kinds of plastic with thumb rings, and you have some that are pressure here. This looks like kind of like a staple gun. And this type right here would be used for when you're going into bone on some different supplemental injections that usually your dentist gives, but you may give them in your particular office. We're not going to do any with that type of an apparatus when you're learning how. We're going to use a normal syringe. Now the C-CLAD, which is the computer, the wand, that is this one. Okay, so that would be, has this long cord. The cartridge goes in here, and then this gets screwed onto the top of this little machine. And the needle is at the end of here. That cartridge, that liquid goes through all of this cord, and it comes out right here. There's no thumb ring on this to be able to aspirate with a thumb ring. So you're going to hold this like you would almost a pencil, and you go ahead and just go into the tissue that way. The thing is with this is the machine aspirates this for you. So it's going to every so often do an aspiration to make sure that, and you don't feel it, it's doing it from the inside. You'll hear some noises, little dings that let you know that it's aspirating, and you can look in the cartridge and see that there's no blood in there, and then you know you're not in a blood vessel, and then you can go ahead and release the anesthetic. They're really cool. We don't have one of these at the clinic, but they are really cool to use. So here's different types of syringes. We have what you got in your kit are these. Well, no, they're not these down there. They're more like you have a ring that's perfectly round like this, but it doesn't have, it has a place for your fingers like these up here. And they're metal and they're not colored. You can get colored ones, but we don't get them. You have an oval ring, thumb ring for smaller hands that is metal, like this one also down here. And it has a place for you to put your index finger and your middle finger right around this these finger grips. So they'll both be metal like this. You'll have finger grips around both of yours, and one is oval and one is round. But they have all different. They have a regular, a small, and they have a petite. That may be the petite. May need, some of you when you're out in private practice, you may need to get the petite because your fingers, you'll understand more when we start to give them what that means. So petite syringes that fit the hands better. Not as many clinicians in the office can use them, so a lot of dentists think it's not cost efficient to go ahead and get those. So if you're going to be subbing at some offices, you need to be able to use any kind of syringe that they have, and you will be able to do that. You can fill up that thumb ring with gauze, and to lessen the space in there so it fits more comfortably, and we'll be showing you that. Okay, so here it talks about a positive aspiration. When you pull back on the thumb ring and you do see blood in the cartridge, that's called a positive aspiration. If you pull up on the thumb ring and you get no blood into the cartridge, then you're not in a blood vessel, and we'll call that a negative aspiration. So what we're looking for is to have negative aspirations. If you do get a positive aspiration of blood coming up into your cartridge, the patient can't tell. They don't feel the blood going up in there. It's just, you know, that a little spring of blood, you know that you're in a blood vessel, and you will pull out and change your cartridge and your needle, and then you will go back in. If it's negative, that's great. Then you can go ahead and inject and at that particular spot. So that's just a safety feature, being able to aspirate. Negative pressure means when you pull back on the thumb ring and only the bubbles, it's a negative aspiration. Negative pressure is called just pulling up on that thumb ring so that you're not giving it pressure, you're not giving it pressure. And that's the negative pressure when you see nothing, when you're not in a blood vessel. So this is a periodontal ligament device. They have a lot of different kind of devices. These are just two of them. It's very common to have something like this. And when you go into bone, like I say, you're not going to be using that. That should be relieving to you. But sometimes in some offices, the dentist or you may go to a course and learn how to do these. It's not absolutely necessary in a general practice, or probably even a perio practice. But once in a while, it's, if you decided to take a little course in this and be certified in it, it's just nice to add to your resume that you are able to do them. So here's the C-CLAD systems, the computer-controlled local anesthetic delivery systems. And there's different companies that make different ones. The one that we had at our office is this one. And these have little green see-through little dots here. And you can set it to go on if you want to give a fourth of a cartridge or a half a cartridge or a full cartridge or whatever that you want to do. But you go ahead, and this has that big long tubing that's you can't see most of it, but you put anesthetic cartridge in the end of here and then turn it upside down and put it in the machine. And then you take the cap off. You go ahead and use it like a pencil, like we talked about before. You go into the tissue while you're rotating. You usually rotate it in a clockwise. You just keep going in a clockwise circle, just very smoothly with your fingers so that it's rotating around. And it sounds awful, but it's a really smooth procedure. And that helps the needle stay straight as you're going in and not like veer off to one side or the other. They're really cool to use. And these will go ahead and let you know when you're getting close to the end of the however much you're going to give them. And it will almost sounds like an old elevator dinging as you're going to each floor. And it will stop and aspirate like about every 5 minutes or so. Or actually it's probably closer than that, every minute or so, to where they'll know that you're not in a blood vessel. They're really neat to use. This is how you would hold it. You hold it like a pencil and then just twirl the index finger. You want it very steady and smooth, but you just make it go around and around as you're putting it into the tissue. So there's problems, the problems that you can get and that you will be I hope this is, should have kind of gone into here, problems. It's on page 95 of the new text. So I changed some other things to go with the new text, but I didn't think about changing page numbers. So it will talk about leakage when you're reloading with the second cartridge. So you've already used one cartridge up and you need to give maybe a cartridge and a half to this particular injection, or getting ready to do another injection, and the needle is already in place, and you need to put it in a certain way with the bottom of the cartridge first into the syringe. And a lot of assistants were taught to put the top part in first, but you could create an ovid little puncture with the needle, which we'll show you when you do it that way. Broken cartridges, if it's a badly worn syringe, you can have a bent harpoon. A needle that is bent and too much positive pressure on the thumb ring can damage the cartridge, leading to breakage. So the harpoon needs to be straight and sharp. If it's off center, when it goes in and punctures like it's supposed to, that rubber plunger of the cartridge, it causes the plunger to rotate as it moves down the glass cartridge, which can cause cartridge breakage. If the harpoon is dull, too much pressure is used to try to aspirate. So it's really important to keep your fingers so that you don't break skin off of that harpoon. And it's really important to make sure that you check them out and that it is not, this is actually page 96 on here, that's correct, to where it's there's too much pressure. Only a gentle backwards motion of your thumb is needed. Harpoon disengages. What if the harpoon disengages during aspiration? You first slowly withdraw the needle from the patient's mouth. You recap it using a one-handed scoop method, which you will be shown. You remove the needle, re-engage the harpoon in the rubber stopper, and reattach the needle. So sometimes you can do all of that without removing the needle. That's even better. Know that as you do this, there's always a little amount of anesthetic that is removed when you are re-engaging the harpoon into a stopper. So if you only had a quarter of a cartridge left and you needed to give that full quarter to a particular injection, and you start taking the cartridge, that empty cartridge out, or I mean the needle out and back in and start re-engaging it, you could lose a little bit of that anesthetic. So you have to be aware of that. So surface deposits, your syringe can get rusted after being autoclaved, and just like your instruments, you can take a little 2x2 gauze or a 4x4 with just rubbing alcohol and rub it across there, and it will take the rust off. So it can also accumulate debris, saliva, disinfectant solution. All of that interferes with the syringe function. So you can put your syringe in the ultrasonic bath and then autoclave it. We don't do that at our clinic. We always did that at a private practice, but we don't do it in the clinic. So not any one syringe is superior to another. All reusable syringes need to be capable of being sterilized or thrown away, if those would not be usable. Non-reusable syringes must be disposed of properly, and there is a way to dispose of syringes. There's a way to dispose of the needles. They need to go into the sharps container, never into trash. A cartridge, an empty cartridge or cartridge that's been used, never, or one that is not good anymore, but it has, maybe the top of the cap is all bent, then you would not use that in, you would need to throw that away and not use it, but it would be full of anesthetic. You still don't ever throw it in the regular trash. You always throw it in, put them in anything that's glass or that can cut, or your actual needle needs to go into the sharps container, which is in that hole by the sink, everybody's sink, and you just share that one sharps container. But you never put them. You also have those red bags, biohazard bags, that are in your operatories hanging on the wall, and that's to put really saturated bloody gauze into. But you never ever put a needle in something like that, because it can puncture somebody else that's taking out the trash. So then they are infected with whatever was in your patient's system. So that is a huge no. All different kinds of needles they have, different colors signify, from certain companies, signify whether it's what size of needle that it is. And so some are just clear, even though there are different sizes. Usually the colored ones are a little more expensive than the clear ones. So it just depends on what your office is going to get. Most needles are stainless steel and disposable. Needles are pre-sterilized and disposable. Reusable needles should not be used for any injection ever. So you only one needle per patient. And when that needle has touched anything like gauze or the bib, or if it touches anything else but that patient's, your hand, something on your tray, then you're going to change needles because you can carry bacteria at the very end of that needle, and then you're going to push it in someone's body, in their system. So they really don't have a lot of issues with that, but we're not going to take any chances. It's ridiculous to take a chance. You're just going to throw the needle out into the sharps container, and you're going to put on a new needle if you touch anything else. And while you're learning, you may well touch other things. And so it's not personal, but we're going to say, please change your needle. All right. So that would be a little bit about that. The anatomy of a needle. You can see that, look at this A line right here, and you can see that the needles need to be straight and going horizontal. Here is the hub of the needle. This is like a needle shaft. That's this part, the shaft, long part of the needle. Then you have a beveled tip. The beveled tip, it's because the end of the tip just isn't to a point like that. The end of the tip is higher on one side than the other, and that's beveled. All right, so it has a little more angle than that I drew on there, but that's called a beveled tip. The cartridge penetrating end is the C over here. That's this long thing is going into a cartridge. The ones that we use are going to be like this. The end that goes into the cartridge is really short. So then you have a syringe adapter. That's this plastic white thing. It's going to adapt the needle into the needle that goes into the patient's tissue and the needle that goes into the cartridge. E is the hub. That's right here. That's the hub. And so there is the hub there. So we use it even right here. This part, that steel part right there, should not go into the patient's tissue. But if you put a needle all the way to the hub right here, it can sometimes easily break off. And then if you give a lot of pressure or something, and so we don't go all the way to the hub. You'll see dentists do that, but we do not do that because the tissue will envelop around it and push the needle further into the tissue, into the patient's mucosa, and you may have to send them to a oral surgeon to dig it back out. So we don't let it get that far. This is the weakest part of the needle, right at the hub. It's the very weakest part. And sometimes we have to contact bone, and we contact it ever so gingerly. We're just barely contacting it, almost just kind of like the resistance that you feel when you let a scaler, like a Gracie curette, go to the bottom of a pocket, and you can't see it, but you can feel it. You're not pushing it down there, but you can feel that. Well, sometimes that's what it's like when you feel bone, and you are just good. But if you go in there too forceful with a heavy hand and a death grip, and you kind of push it into there to where it contacts the bone, it's not only going to hurt your patient, but it could snap the needle off at the hub. So that's, we don't ever do anything. And my whole 10 years at this school, we've never had a needle snap off at the hub because we make sure that it doesn't. Then, of course, you have the needle cap, which could be clear or colored. Needles come in different lengths. I want you to know that mainly they have long needles, they have short needles, and they have ultra short needles. And so this is the part that goes into the anesthetic and screws in there. They're all the same length. This is the part that goes into the patient's tissue, and they're different lengths. You have a long, which is 32 millimeters. It's about 1.5 inches, but we don't really term it by inches. It's just for you to know in your mind about what 32 millimeters, how long that would be. So it's 32, it's 20, and it's 10. So those you need to know. They have an ultra short that they claim will be 12 millimeters long, because you can see the 10 millimeters go from the hub right to here. But they still call these 10 millimeter. Just wanted you to know that there's an extra couple millimeters here that for whatever reason they don't account for, because every other one goes to the tip. But these are actually going to be known by, and you need to memorize 32, 20, and 10. So 32 is a long. You'll use those for 2 injections only. You'll mostly use your shorter needle, which is only 20 millimeters. This is important to know because there are some of the injections that you'll only put, most of them, you'll only penetrate into your patient's tissue up to 5 millimeters. So this is a way for you to, there's no markings on here. This is all an eyeballing it. So it's 20 millimeters long. So you look at about half of that would be 10. Okay, here. And then you're going to have that, each one of those, because 5 times 4 is 20. So each one of these lengths are 20 millimeters on a 20 millimeter needle length. So if you're only going to go 5, you see what the half is, eyeball that, and then see what half of that would be. And this is the only amount of needle that should be going in your patient's mucous membrane, or mucosa right there. And if it says, if it's an injection that uses 3/4 of a needle, which would be the PSA, you're going to half it, kind of eyeball it and half it that way. In the PSA, you put this much, 3/4 of that needle in. So you're just going to kind of eyeball the half mark, and then eyeball what would be half in between here, and you only put your needle in up to there. You need to be able to see only about 5 millimeters. That's a better way. You just keep going till the only part that you see is still 5 millimeters. Then obviously 3 millimeters are in. Same way with a 32 millimeter. Very often it will say go in 3/4 of a long needle. So you need to like half that in your mind, like where a half mark would be. And let's say it would be right here. And then you're going to go half between here and here, would be about right here. So if you're going to go in 3/4 of a long needle, once again, you only want to see 5 or 6 millimeters out here. 5 to 6. And then you know that you're about 32 millimeters in. And if you go that length, you'll be right at your target where you're supposed to go. But if you go past that all the way to the hub, and the tissue is all the way up here, you can't see any of the needle, then that's not a good thing. So we would slowly take retract the needle a little bit. So needle attachment and bevel indicators. You'll see these red dots. They're bevel indicators. Here's the bevel, and it has quite an angle on the ends of all of these needles. And so this is the flow of the anesthetic is going to come out this short end before it comes out the long end. So we always want this bevel facing the bone. All right, and so it's hard to see, it's so tiny, but they lined it up with a red dot on some needles. We don't have some needles that you will have at your private practice won't have that little dot, so don't be surprised. It costs just a little more to have a needle that shows where the bevel indicator is. So you have to just kind of hold it up to the light and see which way that bevel is going, because when you enter into the tissue, you want to enter it with this toward the nerve rather than away from the nerve, like the opposite. So here's all the different kinds of bevels in dentistry. You have long bevels like this. They're sharp and pointed. You have medium bevels. They're rounded on the end. You have short bevels. See how tiny this is, not very long at all. You have multi-bevel. Can you shut the door? Because I don't want to hear you. You have multi-bevel, which is a little, looks a lot like that long bevel, doesn't it? Except this looks like it's kind of curved a little, and this looks perfectly straight. So you have a scalpeled bevel that is right here, and that's probably for different types of surgery. We don't use those. So we are just going to use, I think we have probably, because ours go to a point, so we either have this multi-bevel or the long bevel on our needles. So the bevel defines the point or tip of the needle. It is described as long, medium, or short. A needle whose point is centered on the long axis, it provides the least deflection. Deflection is, when I was describing the wand, the deflection would be if you're taking the needle in to the tissue and you think you're going straight, but that needle is kind of veering off to one side or the other. We want it to go straight to our target. And so we need to get a needle that does that the best. And sometimes your different size needles, if they're thinner or something, they'll deflect more. So we like needles that the point is centered on the long axis, not that are kind of going off in different directions. So the bevel of the needle should face the bone so that it'll face all of the anesthetic that is coming out. Now we're going to talk about gauge. Gauge means the diameter of the lumen. The lumen is an opening. A lumen on anything is the opening. So in this particular one, this company, they have a red cap would be a long. Yellow caps are long or short. I mean, these can be long or short as well. And the blue cap is for smaller 30 gauge. But they're talking about gauges opening of the lumen. Any of them, except for this one, these two can be long or short needles. This is a long needle, 32 millimeters. This is a short needle, 20 millimeters. This is a way short needle, so ultra short is what they call it. And these are all the same sizes here. They're all the same. What's different is the size of the opening of that needle, of the bevel. Okay, so if it is, they call that 25 gauge if you have a larger opening. They call it a 27 gauge if you have a little bit smaller than that, but it still can be considered a large lumen. This would just be larger. And this is a 30 gauge. It has the smallest opening. So it's just opposite of what you think. It's not small 25, large 27, larger 30, like the numbers go. It goes exactly opposite in numbers. So the very largest is the lowest number of gauge, because actually these are the 3 gauges that we use in dentistry and private practice, but there actually are tons of different sizes of numbers of openings of needles and different sizes and thicknesses that they use in medicine. So these are the 3, the 25, 27, and 30 gauge. It just means that the 25 could be long or short, doesn't matter. But if it's red, it has a 25 gauge. If it's yellow, it has a 27 gauge, whether it's long or short. If it's blue, it has a 30 gauge, and that's a really teeny tiny little opening, or lumen, ultra short. So a 30 gauge has a smaller internal diameter than a 25 gauge. So it's just opposite in numbers than what you naturally want to go for. The larger gauge needles, 25 openings on those have advantages over the smaller ones, those shorter ultra shorts. They have greater accuracy because they are a little heavier needle and a larger opening. So they're not going to deflect in the tissue as much as a flimsier needle. The needle breakage is less likely to occur with a large or larger with a 25 or 27 gauge. And it's more accurate on the aspirations because the opening is larger. When you take that, the only reason that we don't have the ultra shorts at our clinic is that they give a lot of false negative aspirations. You can be in a blood vessel and you can aspirate to see if any blood comes, before you inject. You aspirate with your thumb to make sure if you're in a blood vessel or not. And what happens is that opening is so tiny that sometimes it gets clogged up and you can be in a blood vessel, but no blood will come out. So you get a negative aspiration, think you're fine, you go ahead and inject. But what you need to do is, if you have a larger opening, that doesn't happen. So you get a more accurate aspiration, negative or positive aspiration, when particularly a more accurate positive aspiration with your 25 or 27. And in Malamet's book, it's like you can use, patients haven't said that on comfort, they have not said at all that one is more comfortable than the other. There are tiny, tiny little differences between these 3, but enough that some are better than others, but not enough that the patient feels any difference. They've tested this out and injected with all 3 and asked patients which one was more comfortable. They can't tell the difference. Okay, so it's just for our sake and making sure that we're safe with these aspirations that we like to use these. So Malamed in his injections, sometimes he will say use a 25 or a 27 gauge for this particular injection. Sometimes he'll say using a 25, and I think he just didn't include it. You can use a 25 or a 27 for any of these, but we mostly use 25s because it's the largest opening. And we have, I think that's maybe, I don't even know if we have 27 gauges. In private practice, they would be okay to use, but your larger needle with your larger opening on the needle and the strength of the needle is just more of a safety precaution. So aspiration of the blood is easier, more reliable with a 25-27 gauge, so it's recommended. Especially in highly vascular areas, we tend to use the larger one, 25. It could be long or short, and it remains the preferred needle for all injections that have a high risk of a positive aspiration, like your PSA and your IA. So do not ever insert the needle all the way to the hub. So that means all the way to here. Definitely here. Here's the more of the hub right there, but it's actually, in the real world, we do it right there. Now, it's a great way to have breakage is at the hub. The hub's the weakest part of the needle. Remember that. And if you can still see a little bit of it sticking out, you can retrieve it with a hemostat. But if, like I said before, it sometimes can quickly go into the tissue, and then the tissue comes up and over it and kind of pushes it further in. So this is what we're talking about, deflection. So this would be like, I don't know if they use glycine soap or what, but you can see on both sides, here's a 27 gauge, which has a medium size. It says it's not the 25 with the largest opening, but the 30 gauge is the one with the smallest. So here they're talking about, they're using a regular syringe. Here they're using the wand on these two. So when you use a regular syringe and you go into a bar of soap, you think that you're going straight like this. Well, that's like not real straight. Can't draw with a mouse, worse than on the whiteboard. But you think you're going straight, and after you get up to about right here, the needle starts deflecting off here. Well, if you're trying to hit this nerve, you know, all those nodes on a nerve that's going this way, then obviously your patient may not, you're doing everything correct. It's just that this is deflecting off in another area. So sometimes if they don't, they come out of anesthesia quicker than you want them to. And you think, gosh, I know I was right on the all the landmarks, etc. It could be needle deflection. And the 30 gauge is really bad about that, and so is the 25. Now, when you use the wand, you are entering kind of like this. I mean, in like little circles as you're going in. You're rotating this around between your fingers as you're going in, and that helps it stay straight. So look, when you use a computer controlled, how straight that those stay. I mean, they're really, really nice. So 25 gauge needles are recommended for highly vascular areas. They did not test a 25 on here, but they have much less deflection than either of these. 30 gauge is the most often purchased. They're really, that 30 gauge ultra short, you have so much control over those with those needles. You don't have this big long needle that you're worrying about. And this is when you have to do most of your injections. You're only going to be going in the tissue about 5 millimeters of that needle. So only like this much. So it doesn't really matter if you use, you'll always use a short for this. But let's say you use an ultra short. Well, you're only going in 5, so you can do that with a 30 gauge needle. But it can be aspirated, but once again, it's the most often purchased, but it's the worst for being able to tell if you're in a blood vessel or not for aspirating. But you can use those. They're a lot better for just infiltrations. It still is a little difficult. You have to worry about if you're getting a false negative or, but we're only going in just a little bit, so it doesn't really have all that long of a time to deflect. It usually stays about that much, like here, before it starts deflecting off. So there's about, you know, maybe 4 or 5 millimeters in here before it starts going off. So that may be okay, but still it's an issue with the aspiration. Never use on more than one patient, of course. Every 3 to 4 injections, penetrations into the tissue, you need to change your needle. So it dulls the needle. Dull needles cause pain when you insert them. If you do 3 different injections, even just going in through the tissue can kind of dull a sharp needle a little bit. And so you will if you go into one and give a quarter, and then go into another area and give a quarter, and then go into a third area and give a quarter, you might be able to get by with the fourth one so you don't have to stop and change needles. But I truly, after every 3 to 4 penetrations, you're just going to change your needle, because it's more, if it dulls over, then it hurts the patient a little more as it's penetrating the tissue. If you get something super sharp, it just goes straight in. So you always know where your tip is. You've got to have your eyes on the tip of your syringe when it is at the tip of your needle, when it's in the syringe, so that if you are moving it from your tray over to the patient, you need to have your eyeball on that tip of the syringe. If they all of a sudden move their arm up or cough and they're kind of flail a little bit, their arm could be in the tip of your syringe. So you need to know where that is at all times. When you take it out of the patient's mouth, you are going to use the scoop method, one-handed scoop method, which we'll be showing on next Friday. And we are going to show you how to do that. And you are watching the tip of your needle until it gets recapped and clicked in of your needle cap. So bending weakens the needles. A lot of dentists will bend the needle, making them more likely to break when you contact, even though you contact bone really just ever so slightly. When you inject or penetrate into a patient's mouth and you realize that you need to be to the left a little bit on where your landmark is, you don't just move it over there. On the inside, it'll tear the tissue. What you need to do is, like you're backing up a car and going to do parallel parking. You just kind of back it up and be moving it in the direction that you want to go as you're backing the needle up. Then you stop and then you go forward, and we'll be showing you that with an orange. You'll be able to see that better. So sometimes you have to completely withdraw it completely because you're really way off. But sometimes if you're not that far off of your landmark, we'll put our hand on your hand and we'll kind of guide you back and guide you in the right direction. You'll see how to do that. So no attempt should ever be made to force the needle against any resistance. The needles are not designed to penetrate bone, just lightly come in contact with the bone. If you have pain on withdrawal, they have fishhook barbs. And there's lots of great pictures in your text. Fishhook barbs are little tiny little metal shavings that when you do even slightly contact bone, it can kind of make these little barbs that come out, these little microscopic barbs. And so if you keep using that needle over and over after you've contacted bone a couple times, then as you are putting it into the tissue, penetrating for a third injection, those barbs are going to hurt the patient going in and coming back out, because barbs would hurt if you were going either direction with that needle. But if you have a dull needle, it's only going to be painful on the way in. If you're withdrawing that needle and it's dull on the end, if you're going backwards, then the dull needle doesn't hurt when you withdraw. But fish hook barbs will be painful on insertion and especially on withdrawal. So if they have pain on insertion, you probably have a dull needle or fish hook barbs. Injury to the patient or administrator. The major cause of any needle injury is inattention by the operator. It's an operator issue. So we always need to know where the tip of our needle is. It's in case the patient suddenly jerks and we recap the needle the second that it comes out. It is the first thing that we do. We recap it and click. Wait till we hear the click of that cap on the needle before we even suction. Even if the patient is kind of gurgling a little bit, we don't just ever lay a needle with no cap or like a syringe with a needle with no cap on our tray. You cap it real quick and then you go on. So what it means is we like for a cap, a needle cap, after we've taken it off, to be in a certain position so that we can quickly come back to it and cap it with a one-handed scoop. OSHA, recapping or needle removal must be accomplished through the use of mechanical device, which is a syringe, and a one-handed technique, which is the scoop method. And that's by OSHA. So they recommend never bending any part of the needle before you discarding it. And the scoop method, which is a really simple one-handed method of recapping a contaminated needle. So the comfort is maximized by use of a sharply beveled needle. So this is the scoop method, although you can't really see it. You are finished giving the injection, and so you have your needle cap right here. You come in at this angle, then you kind of lift the cap on end like this, so that you can slide the needle in and click that cap in, and then you can put your syringe down. Here they've done a modified scoop method. They have gotten a pair of pliers and stuck this needle cap in the very end of it so that it can hold it upwise, and then you can just go into it. But it also needs to be done with a one-handed method. Here are other needle recapping devices. They have a card. You guys have this. If that looks familiar, it's a version of that, and we'll show you how to make that work. These are really great. They weigh a lot, and so they don't tip and roll around on your tray. And you just, when you take your needle cap off, you put it here, in here, and you just wait to come back, and then this heavy thing holds that cap in. But the deal is with these, you'd have to have, if you're in a private practice, you'd have to have, if you see 8 patients a day, you'd have to have 8 of these. They need to be autoclaved, in between uses, and they're expensive, and you can do just as well with a scoop method or what you have here. These also need to be autoclaved after every use, after they've been on your tray. And then we have cards with holes in them to where when we take the cap off, we'll put the end into this little hole and it kind of sets up on end. But there's all different kind of devices that your private practice will have. And my private practice, the one that I worked the most at, had nothing. We just had to put our cap on the tray and scoop it up, and it was fine. So unsafe recapping practices. You never hold on to this with a hand and put your needle toward it, ever. Because if someone comes up and bumps you, or they're going to lean down and tell you something, they don't see what you're doing, that needle's going to go right in your thumb. And it can happen so fast. So we don't do it that way. We don't hold it on the back side, because this needle is pretty easily can go through. There's a little bit of resistance, but it can go through this cardboard. So what we do is we don't touch the receptacle at all that we're scooping into, whether it's the metal, the cardboard, just the cap alone. We don't touch it with our other hand. That's why it's called one-handed method. We use one hand and we will scoop into it like this. This is the best practice with a card. That card will stand straight up because, or if there's kind of like a triangle, like a picture frame would be, with a back piece on it, and that's what the end of that cap is doing. It's setting on the tray. So it will hold that up so you can go back into that hole easy, and then you need to kind of bring the whole thing up and click it on like this. and press down on the table because that clicks the cap in. And once you hear that click, then you're okay. Then you can take the card off or on. Okay, so we don't use the other hand at all. This is the basic scoop with a rubber prop like you have. When we take the cap off, we're going to put that that cap into here so that it also kind of sits up and we can easily go into it. But we don't handle the back of this ever until the needle is firmly capped. So it will show you when you're even if you're just withdrawing it, you don't hang on to that with your other, well, I guess they're showing that you do that as a best practice. I don't even know if I guess you can do that if you're withdrawing. Just hoping that no one comes on the back of you and you know, like that arm gets pushed in a little bit, but it hasn't been used, hopefully, at this point. So withdrawing, I guess you can do that. The incorrect way is when you're going back to the cap. That would be mostly what is wrong. Okay. Insert the scoop method with one hand. You're going to put the needle almost like 3/4 of the way in there, and then you're going to stand it up on its end and click the cap on tight. And this is just showing another way that when you're inserting the needle, you never, ever hold on to it. When you're going to dispose it and you're putting it in a sharps container, they have a container that's square that looks like this. The needle disposal, you can put the whole thing on top. You can hold it from the back because the needle cap is on there. And even if the needle cap is not on there, if you drop it on the floor or something like that, then you would not go down and pick it up. When you drop things on the floor, you don't ever pick them up in front of the patient. They don't know where you're putting that, and it looks like you're putting things back on your tray. When you drop something off of your tray or the needle cap, you are going to leave it on the floor and just move it with your foot until after the appointment is over. Get up and get another whatever that was down there that you need. If it's an instrument, get up and get another one from the closet. But so in this instance, you put it upside down over the hole of the sharps container. A lot of assistants, a lot of dentistry does this to the short end of the needle that goes in, or that did go into the cartridge. And they do that because they have so many needles maybe on their tray that they want to make sure that everyone knows this needle's been used. So don't reuse that needle. So they kind of put it on a surface and they bend it. We don't do that. We're just going to leave them straight. We don't put the little tiny cap. We don't scoop that little tiny cap up in here either, because it's a big risk on that short of a needle to get a puncture on it. We just leave it there, leave it straight, and we will discard it into the sharps container. This is a syringe grasp. You hold it where your palm up. You never put the palm down and use it that way. You always have your palm up, your thumb in the thumb ring, and your index finger and middle finger on the underside of this finger rest. And you can put your when you put your ring finger up like this, it steadies that cartridge. We need to fulcrum on the face, somewhere on the face when we are giving an injection for stability so that it's not shaking. But until you get to the face, this finger, and this is the finger you're going to do it with, your ring finger, but sometimes you can do your pinky, but this pinky really doesn't have any other use. It can just kind of be hanging there, and you'll see what we're talking about. This chapter on the cartridge is chapter 7, and I'm going to let you kind of look at a lot of it. I'm going to point out a few things here that we use the word cartridge. You can see in here that a lot of people say carpule. It's actually not correct. You're going to hear out in the real world the carpule being used all the time. So don't correct anybody, but just for your knowledge, and it may be on a board question of whether carpule is the correct word for a cartridge. And it's actually not, because the word carpule is a registered trademark name for a dental cartridge, and it was prepared by Cook Weight Laboratories way back in 1920. So it's the difference between calling a tissue a Kleenex. It's actually supposed to be called tissue, and a company that makes tissues is Kleenex. But everybody just says a Kleenex, whether it's from one other company or it's from an actual Kleenex. So it just caught on, and that's what people do, and that's what people do between the word carpule and cartridge. But in our clinic, we are going to call them cartridges, so that hopefully it sticks in your head and you don't like miss a really easy question if it would happen to be on boards. So this, in the United States, this glass cartridge, the cylinder itself, can hold 2 millimeters of solution. However, it contains approximately 1.8 milliliters of local anesthetic. And that's because of it can hold up to 2, but we try to get it more to 1.8. There may be a few more drips that go into that particular cartridge. So here you have the glass cartridge, which is A. You have B, this is called the rubber stopper, and you have an aluminum cap, and this is the diaphragm. This black in here is the diaphragm. This is what your needle is going to penetrate to go into the cartridge. And this side is what your harpoon is going to penetrate to push it. So there's a mylar plastic coating that is surrounding the glass. You can barely feel it, but it helps if the glass does break, the cartridge breaks or shatters. And sometimes it's because someone has dropped it. Sometimes it has come from the manufacturer with little tiny breaks up in the neck of the cartridge. So you have to kind of look at those and see. There's color coding if depicted on the standardized local anesthetic. The contents you're going to need to know. It has local anesthetic, whatever you're using, lidocaine or 3% mepivacaine. Then you have sodium chloride. That makes the solution more isotonic with the body tissues. So it has local anesthetic, it has sodium chloride, then most of it is sterile water. So they use distilled water, or they use sterile, it'll be called distilled water or sterile water is the diluent, and it provides most of the volume. And then if you have, those are the 3 things that would be in a cartridge if you're using a plain cartridge or plain anesthetic, like 3% mepivacaine plain or 4% prilocaine plain. It would be just those first 4 things. So then if you have you're going to use a vasopressor or vasoconstrictor, in other words, they would add the epi or levonorepinephrine, and that's going to increase the time you can have and increase the depth of anesthesia. And if they have a vasopressor in it, they've got to put a preservative for that vasopressor. So if it has epi or levo in it, then it's going to have sodium bisulfite. And that's the preservative, and that is the sulfite part of that is what people might be allergic to. they're never allergic to the actual, there's no allergies to the actual parent compounds, whether it's Lido or whatever, it's the breakdown, like there's some allergies to the breakdown of these, but not to the actual parent compound. And I keep saying that over and over because that is going to be a test question, either in the quiz or on midterm or boards. So these are all the different color codings. You have some that have gold caps, your Articane. Most of them have silver aluminum caps. This has a gold colored aluminum cap. The ADA, the American Dental Association, made this color system. So you can see that in real time, if they are next to each other, you can tell the difference. But mainly these two, Articane and Mepivocaine. If they were right next to each other, you could see that there was a difference in color. But if you just have one or the other on your tray, then so you have to read it. You have to go, okay, you have to know what you're giving your patient, in other words. This is the label on your cartridges. This is lidocaine because lidocaine is red. So I just know that. It'll say 2%. It'll have this number in here. It'll have the 2%, the brand name. If it's xylocaine, it may be 2% xylocaine, which is actually lidocaine. And it'll say with epinephrine, it'll give the ratio 1 in 100,000. And then below, it will say what the parent compound is. It'll say lidocaine and epinephrine injection. Then it will give the manufacturer's name, and it will have a lot number. So if we have bad bunch or something, we can tell, like if the caps are dented or we find little cracks, little minute cracks up here in the neck of it, we can call the company and tell them what lot number that those came from. So it has a lot number, and a really important thing here is the expiration date. We've got to make sure that sometimes we throw out anesthetic in the clinic because it's over. We haven't used that much of a particular kind of anesthetic, and when it's over its expiration, it's no good anymore. So you have got to look at the expiration dates in your office. We keep really good look on that in the clinic, but every once in a while, if some of that has been, if it's in the cabinet, it's usually fresh and new, but sometimes we keep some anesthetic up in that tiny little supply closet in the actual clinic, and it's up in a tub. So we have to kind of look and just make sure. It could have been an oversight to look through those to take out the ones that are expired. Like I'm going to use all expired anesthetic, kept back a few boxes when you inject oranges because it doesn't need to be good. So that's a good use of that. So dosage calculation, the total drug volume will be 1.8. And here is where it's saying with epinephrine and some of the writing that will go around in there. This is lidocaine because it's red. It'll be a 2% lidocaine within 1 in 100,000 epi. And so when they talk about a stopper full, this looks a lot longer right here than this does. But when you get to the clinic and actually look at the stoppers, they're almost the same size. And so when we say give this just a stopper full, you're going to give just 0.2 milliliters. You're going to give just about this much. It'll go from here to here. And that's how much you're going to give, because it should, in real life, it's like, I feel like this is kind of large. In real life, it's about that, like that. And so this is a stopper right there, and you just take that measurement and double it, and you come down to here. So you give a stopper full, which is 0.2. So there's 1.8 milliliters, and you can divide that out by 0.2, 0.4, 0.6, 0.8, 1 milliliter. So if you're giving a half of a cartridge, you're giving about a milliliter only. If you're giving 3/4 of a cartridge, you're probably giving more, about right in here. Like that. If you give a full cartridge, you're going to do your calculations on 1.8 milliliters. So, that's just so that you can kind of eyeball what 2 and 2 and 2 would be if you're going to give maybe a third of a cartridge to somebody, like if infiltrations take a third for an infiltration. So you would need to eyeball this into thirds. You would need just to kind of eyeball it into thirds. And for an overdose reaction, probably wouldn't be right there. For an overdose reaction, you have to give a lot more, like maybe 5 or 6 or maybe some up to 10 cartridges for an overdose effect. So if you're just a tiny bit over when you're eyeballing it, it's not going to be a big deal. What is a big deal if you're giving a lot less. So you want to make sure that in order to really anesthetize that infiltration, you really do need all of that 1/3 of a cartridge. So here's calculations of milligrams per cartridge. The percent of the cartridge, you can see right here, milligrams and milliliters, and volumes. We are going to wait on this till we do all of our calculations. We're going to go on to the vasopressors or vasoconstrictors. They're included in most anesthetic cartridges. And what they do is they enhance a lot. They can enhance the safety, their duration, and the depth. The pH is lower, so it's more acidic because it has this vasopressor in it, and it has to have the preservative. So that makes it even more acidic, which just means it's going to kind of burn more for the first, 5 seconds or so until your body buffers the pH even again. Methylparaben used to be the bacteriostatic agent that made sure everything was isotonic in cartridges. And back in 1984, the FDA took methylparaben out because repeated doses of the paraben had led to reports of increased allergic reactions because of the PABA in paraben when it breaks down. So they took methylparaben out, and I only add this in there because the review books will say the contents of a cartridge are everything below except for 1. And they'll put methylparaben in there. Okay, methylparaben is no longer in there. So usually that's the one that you leave out, and the other ones will stay. Care and handling of the cartridges. They're marketed in clean and uncontaminated blister packs. So they're sterile when you take them out of those blister packs. Then when we pile them up back there in a little container, they're no longer sterile, but they're sterile enough, nothing has gone into the top of that diaphragm. So we don't want to be rubbing across the top of the diaphragm because that's what the needle's actually going to be going into. When you breech load, which is side load a cartridge, the rubber stopper, the bottom should go in first, and we'll, like I said before, show you that. They also have cartridges that are in round tin containers with a top on them, and there's about 50 cartridges in those. You can get those. Most people use the blister packs and not those round containers. You always want to store your anesthetic at room temperature. Heat can destroy the vasoconstrictor, so you don't want to store them by a window where the heat is going to come in from the sun, and you don't want to store them by anything that's warm. So usually better in a dark cabinet somewhere. You can wipe the end of the diaphragm with a sterile gauze and or rubbing alcohol, but you got to be really careful about the rubbing alcohol, because that can eventually, if you put a lot on there, it can seep through that rubber, and then that's going to really sting. Okay, so if you have to wipe it off with rubbing alcohol, it should be the smallest amount and quick. Cartridges should not be permitted to soak in solutions of any kind. Sometimes they would send cartridges in a certain solution to make it more sterile. And those solutions, just like the alcohol, they're going to sit in there, so they can really have an opportunity to soak into the cartridge. And cartridge warmers, they have those very much like baby bottle warmers. They have cartridge warmers to warm them up. Some people especially in the winter, their heat doesn't go on till in their office till a certain time of the day. The office is cold, so the anesthetic that is in a storage room or something is getting cold, and it's much more comfortable at room temperature. So they'll put a bunch of cartridges in these warmers, and it's not really recommended to do, because just like a baby bottle warmer, you've got to really test that out in case it's too warm. And you don't want that to happen with your anesthetic. Plus, it's heat and can destroy the hotter that if it gets real hot, it might destroy the workings of the vasoconstrictor. So hand warming has really proved the best. It's the preferred method to warm a cartridge directly before you insert it in the syringe. You put it in the palm, you put your hands together, palm side together, and you put the cartridge in the middle of your palms, and you rub your hands together back and forth, and that kind of a bunch of times, and that can warm it enough to room temperature. So you're going to see bubbles in the cartridges, and you'll need to know, it's on test questions, that it's a nitrogen gas bubble. It's not hydrogen or air. It's not an air bubble in the cartridge. It's nitrogen. And so there'll be a little bubble sometimes. You can see a bubble here. You shouldn't see, it should be up under the cap if it's everything is good. And that's perfectly normal. It's purposely bubbled by the manufacturer, because that's how they get all of the oxygen out of, that cartridge before they seal it up, is that they will fill it with the liquid, and then they blow a little nitrogen in there to get rid of any oxygen and quickly cap it. So that's a nitrogen bubble, and it does do anything. So this would be a cartridge with no bubble. Like, why doesn't it even have a bubble? This is it doesn't have an air bubble. There's no extruded stopper. This should have, this is down here is what an extruded stopper is. This has an air bubble, and that air bubble somehow in the manufacturing of this, maybe they forgot this load, or the nitrogen wasn't working as well, but there's a big air bubble in there, and the air bubble is pushing this rubber stopper out the end. That's called extruding out. And if you see one like that, then you need not to use it. That's not good. The air bubble, your stopper should be just a little inside the glass case. There should be a little glass still showing out the bottom that comes out, and your stopper needs to be on the inside. So it's usually like a larger bubble, 2 millimeters, that may be present with a plunger that is extruded beyond the rim of the cartridge. And what that is how they got the air bubble in there most of the time is because maybe the nitrogen wasn't working, but most of the time it's because they froze it to keep it when they're taking it on big trucks from one part of the country to another part of the country, and to keep it fresh, they might freeze it. And so when it thaws out, there's going to be an air bubble in there. So when we find something like this, cracks on the cartridge or an extruded stopper, rubber stopper coming out the end, we don't throw those away. It'll be a test question. We return them to the manufacturer, okay? Because even if it still looks okay and it's just an air bubble, you can't assure the sterility anymore of that local anesthetic. So if anything is wrong with that cartridge, we can't be sure that it's sterile, but we don't throw them in the sharps container. We put them in the box and we send it back to the manufacturer. So the stopper can extrude beyond the end of a cartridge when a cartridge is frozen and the liquid expands. So it's no longer sterile. Don't use those. Extruded stopper with no bubble is indicative of a prolonged storage in chemical disinfecting solution. And it has diffused into the stopper. So it has no bubble in it anymore, but it does have an extruded stopper, rubber stopper. If you have burning on injection, the causes, it's a normal response to the pH of the drug. It lasts about 1 to 2 seconds. It's quite normal. Maybe it lasts up to 3 to 5 seconds, but really it's no more than that. It just feels like it's longer. The cartridge could be containing sterilizing solution, which would make it burn. It could have been overheated, or it could have just a vasoconstrictor in it. If you have a corroded cap, and that shows on page 107, I don't think that's, well, maybe so. Okay, on 107, that's not correct. You'll be able to see pictures, really great pictures of fishhook barbs on page 108 of the needles, and that's microscopically. In fact, I do want you guys to go look at that, the fishhook barbs on 107. And then you can look at 115. Look at that chapter on, it shows cracked glass on a dental cartridge that's never been used, kind of on 118 and 115. And the corroded cap is on 118. So it has a really good picture of a local anesthetic with a damaged cap. So it's just like the vegetables or canned goods that you have at your grocery store. If they are dented, it could change the inside of the contents, and we do not use those. Okay, so we'll return them, any kind of a dent. So it can be corrosive. Sometimes you're going to find corrosion. It looks like a rust or something up around the cap container, and that's because it has been sitting immersed in cold sterile of some type. So we don't use anything like that that doesn't look perfectly correct. Rest on the cap. At least one cartridge in a tin container has leaked or broken, creating a crust. Don't use those. Leakage during injection occurs if the cartridge and needle are prepared improperly and the needle puncture is ovoid instead of round. In your text over the chapter of needles, it shows you what we mean by an ovoid. Cutting the diaphragm in an ovoid manner, which is how you really have leakage. Most common broken cartridge, most common is the use of a cartridge that has been cracked or chipped during shipping. That's really tiny to see, and we forget to hold it up to the cartridge up to a light to make sure there's no tiny little fractures. We're going to return the dented caps, and broken cartridges, and need to just take a quick look up into the light of the thin neck for cracks on the cartridges in a packet, and of course return everything. So additional things that you might need, additional armamentarium, would be these things that you might need on your tray. So these are some things you will have you put some topical with a cotton tip applicator right here on your tray on a piece of gauze. And you'll need your needle, and you'll need your anesthetic and whatever syringe you're using. And then the pliers and the hemostat here are used in case you have a broken tip and you need to get in there real quick. We don't put these on our trays here, but you may have them always in private practice. We had those in the very first drawer. We knew right where to get those quick, just in case we had an accident of some kind. Never did, but just in case. Here's your rubber capper and your mirror, of course, and they're using this as a retractor, a cheek retractor, but you don't have to have one of those. So this would be a tray with everything on it, and that you would never carry it around with this over the side right here. You'd put everything on your tray and take it to with the anesthetic and the needle and your syringe, and take it over to your operatory. So total antiseptic. We used to prepare the tissue at the injection site before we penetrated it with the needle. So Malamed suggests to do that on every single one. And what they're actually saying is take a little tiny bit of Listerine with alcohol or chlorhexidine or whatever, a little tiny bit in a Dixie cup, and take it over to your tray, over to your operatory with a cotton tip applicator. And wherever you decide, okay, there's my landmark, there's where I'm going to penetrate with the needle, then you would take a little bit of that and swab over that area just to get the bacteria clean before you penetrate, so you're not pushing bacteria that may be on the inside of the mucosa into the patient's body. We usually have our patients pre-rinse and to reduce the bacteria, so you can just use the pre-rinse as the same as putting that antiseptic on. So what that does is it minimizes any post-injection infection of anything that may have been pushed in to the inside the body. So small amounts of topical antiseptic containing alcohol can be used. If you use large amounts, it could produce some tissue irritation. So we just use a really small amount and rub it over there for 5 or 10 seconds. Post-injection infections can and do occur. So we have regular use of antiseptic virtually eliminates any of that from happening. So if you choose to go ahead and use the antiseptic with a cotton tip applicator, that's okay too. If the antiseptic is not available, you can use just a sterile 2x2 gauze to wipe the site, but it would need to be sterile. Then we're going to place the topical anesthetic. Should be on there for at least, it says 2 to 3 minutes, but really around the 2-minute mark is used most, and some say 1 to 2 minutes, but 2 is really the absolute best. Benzocaine topical is the most used. It stays at the site, and it's not absorbed systemically. So it's an ester, and it does not dilate all of the tissues around it as much as the lidocaine does, because it is not water soluble, so it tends to sit on the tissue a little bit longer. It's not absorbed into the body, so we don't have to worry about an allergic reaction. So only lidocaine is concentrated enough to work as a topical, but lidocaine, it's in a 5%, but lidocaine has a greater risk of overdose because it goes into the system so fast. It's a 5%, and it goes into the system with the vasodilation so quickly. So it has a greater risk of overdose than with the benzocaine, with the ester. So it is available in gels, pastes, and sprays, as we've seen before. EMLAs, eutectic mixture of local anesthetic, do not work really well as a topical for injections. So we don't use those. If you use a spray, it needs to be metered, where when you spray, it sprays out a certain amount. The amount that you need. If you have an unmetered spray, those can be a little dangerous because you don't know when to stop spraying. You just keep spraying and spraying, and that can be irritant to the tissues. It's very difficult keeping a spray nozzle sterile, so that's why they put the little plastic straw like things in the end of the nozzle. Some topical anesthetics contain preservatives such as methylparaben, which can lead to allergic reaction. So they took methylparaben out of the anesthetics that we inject with, but sometimes you have to, it could possibly be in some of your topical anesthetics still. Applicator sticks, always use a clean applicator stick on a tray. That means you're going to be, if you're going to give 3 injections, you will take 3 cotton-tipped applicator sticks, and you will put topical on them back in the sterilizing room. You'll put those on a clean 2x2, and then you always take one that doesn't have anything on it, a plain one. Doesn't have anything on it, because that's the one we're going to use to go around the mouth to where you can see, is this it? Is this where I need to go? And we'll be moving that around so you can get your target area, your landmarks. Cotton gauze, wipe the area of injection of a gross debridement before needle penetration. So we would always need to, someone that's having a gross debridement is someone who comes in and their mouth they've got gingivitis, they've got materia alba everywhere, they've got plaque and food particles everywhere, and what they're saying is, on the person like that, you need to wipe the whole area first before you penetrate in there. Drying the mucosal membrane aids in soft tissue retraction and for increased visibility. And it also is easier for the topical to absorb quickly if you dry the area off. You don't have to, but it will work a little better if you do. The book says to use a 4x4 gauze to stop bleeding, and even tie floss around the gauze for easy retrieval. After you've had bleeding and you scrunch it up and lay it in the vestibule for a period of time, they tie gauze around the middle just so that the patient won't accidentally gag on it or swallow it. And if they do start having a problem, you can just jerk the end of the string out and it will come out of the mouth. Hemostat, primary function is to the removal of a needle from the soft tissues of the mouth. just in the unlikely event that the needle would break off and go within the tissues. Preparation of the armamentarium. You get a breech loading, which is a side loading metal cartridge type syringe. You're going to remove the sterilized syringe from its container or its package, sterilized package in front of the patient. So you retract the piston fully before loading the cartridge. Insert the cartridge rubber stopper end first. Engage the harpoon by gently pushing the piston forward until the harpoon is firmly engaged in the plunger. Insert the needle first causes one to have to hit the piston too hard and can cause glass breakage. When inserting a second cartridge, hitting the piston may be necessary, and I'll be showing you all the difference of that when we meet. Attach the needle to the syringe, expel a few drops to ensure proper flow, and then you're ready to use. So recapping the needle, one of the 2 times that's most likely to accidentally stick yourself with a contaminated needle is when you are recapping the needle. Use the scoop method or place in the needle holder to recap, then remove the syringe from the needle holder and lay it on the tray. So after you administer local anesthetic, you're going to make the needle safe first before you do anything else. You're going to after you do that, you're going to retract the piston, pull the cartridge away, and remove the harpoon from the plunger. So I think the rest of this I'm going to be able, those of you who have been in the industry will be able to follow along pretty well. But those of you who have not been in the industry, you're going to see better by hands-on, and that's what we're going to be doing. So I'll let you read that.